All right, shall we start?
Okay, sir.
So I'll share the screen. We'll talk about clinical assessments today that is relevant to any clinical setting. And the objectives of this class are using a common assessment method that is applicable in any clinical setting and doing it efficiently and quickly, right? And then how to record and present information. This I prefer to do this as an interactive session. So instead of typing in the chat box, I would prefer if you can speak up and we can have a discussion. Now, some patients with the mental health problem could present only with physical symptoms, right? For example, a patient could present with lethargy, poor sleep, or generalized body weakness. If you see such a patient, what would you consider as a possible diagnosis?
Depression.
Yeah, you may think of depression. And in this kind of a setting, some medical illnesses could present with altered feelings and behaviors, such as irritability, anxiety, and feeling low or depressed. What would you consider as a possibility in this kind of a setting? I'm asking about a medical diagnosis.
Encephalitis.
Encephalitis, anything much more common than that? Encephalitis they would have fever commonly as a more prominent presenting symptom, and more
Thyroid
neurological.
disorders.
So
What sort of?
hypothyroid.
Yeah, yes, could be hypothyroidism, could be hypothyroidism. So that is one of the things that we consider. We need to have an assessment method that we can use irrespective of our clinical setting, whether we are in the psychiatry ward or in the outpatient department, surgery ward, medical ward, wherever we are, we need to have a common assessment method for patients, because we don't know before diagnosing, we don't know what kind of diagnosis that we are dealing with, whether it's psychiatric or medical or neurological or whatever. We don't know that, right? Before knowing that, we can't apply, let's say, psychiatric assessments for a particular patient. This is especially relevant in very general settings like outpatient departments. Now, most of you, almost all of you, will work in general settings before specializing in whatever interested specialty. After MBBS, you will work in general settings. So you need a general assessment method to deal with the patient that you encounter. That's one thing we will discuss in this session. The other thing is now how to do assessments efficiently and quickly in clinical settings. Now, how long does it take for you to do an assessment in general for a medical student?
So around 1 hour.
Right. So have you seen doctors working in the wards or outpatient departments or any setting spending 40 minutes or 1 hour or even half an hour assessing a patient? I don't think you have seen. We don't assess patients for half an hour or 45 minutes or 1 hour, right, during our ward rounds. So in the clinics, we can't do that. We don't have that time. And we assess very quickly. And we generally can come to a reasonable diagnosis. Right? And this outline of the clinical assessment, the components, you are familiar with this. You see this in any general psychiatry textbook. We don't take history, so do assessments according to this order. Right? We do quick assessments in a short period of time, and we follow a different method, right? Something unspoken that's not written anywhere, but we definitely don't follow this. You haven't seen us follow this method. So what do we do? And how do we make such efficient and quick assessment? If you can learn that and apply that in your clinical assessments. That is something better than what you do, I guess. When we do clinical assessments, when experienced clinicians do clinical assessments, we follow this sequence, right? First, we try to understand the patient's illness experience. That is what the patient is experiencing. What are his symptoms? How does he experience his symptoms? Right? We try to understand that. We call that the clinical picture, in other words. And then we try to think of possibilities for that clinical picture. I will take an example and go through this sequence, and then this will be much clearer for you. Now, this is the second step. Then first we try to understand the clinical experience, then we think of diagnostic possibilities. Then after that, we try to differentiate between those possibilities and try to arrange that in a hierarchy with the most probable differential diagnosis on top and the least probable at the bottom. And then if possible, we try to come to the most probable diagnosis for that clinical picture, and then gather more information about possible etiologies and then data relevant in management, etc. That's what we do. This is the logical sequence that we have in mind, and this is what we follow. Now, if we take an example, now, the first question we ask when we come across a patient is, what brought you here? What brought you to this place, ward or the OPD or wherever? We ask such an open-ended questions and invite the patient to come up with their problems. The patient might say something like this, right? I feel lethargic and sleepy all the time for last 3 months, and I have lost my appetite as well. එහෙමනේ කියන්නේ මට ඇඟට අමාරුයි, නිදිමත ටිකක් හැම වෙලෙම නිදිමතයි වගේ මාස 3ක් විතර තිස්සේ බඩගිනින්නෙත් නැහැ. And then we wait till the patient finishes. That's something that most of us don't do. We won't let them finish and bombard them with our questions. Now, this is the most important moment in our clinical assessment, the most important component. A good amount of time, 1 to 2 minutes, generally spent in this section, will save us a lot of time later in the assessment. If we get the clinical experience of the patient right, then we can come up with possible differential diagnosis, and that comes handy for us later in the assessment. So the patient will say something like this, right? And then we usually ask, do you have any other problems other than what you stated here? We try to gather as much information as possible to get an outline of the presenting complaint before going into details of each complaint, right? Each symptom. Now, the patient who said the above thing, that they feel lethargic and sleepy and lost their appetite, when you ask the next question about any other problems, they might say they have menstrual problems as well, and they feel fatigued often, right? And then only we go to the next step, that is asking them to describe a little more about each symptom, right? Now, what we try to do here is to get an idea about the patient's experience, clinical experience. Now, this is what you get here. Now, we try to understand the illness experience, and after these questions, the few questions, you get a description like this: feeling lethargic and sleepy all the time for 3 months, lost appetite, and have got heavy menstrual bleedings and feeling fatigued. Now you consider, that's what we do. We think of possibilities for this clinical picture. This may not be the complete clinical picture, but we have an outline now. Tell me the possibilities that you think of for this kind of a presentation? What could be the possibilities? I'm not asking about psychiatric illnesses. Now, think of a general setting that you came up with this kind of a brief description. What are the possibilities?
So maybe due to hypothyroidism.
All right. Anything else?
Anemia.
Okay. So this is what I would think of for this kind of a clinical presentation. If you think of any other possibilities, you can let me know. Do you all agree with this? Do you have any other suggestions for this? This is what I mentioned in that note as most probable diagnostic possibilities, right? Then we try to differentiate between this. Now, you can see we are considering differential diagnosis right from the beginning of our assessment. That's what we do, right? Rather than going step by step, presenting complaint, history of presenting complaint, personal history, family history, then doing the mental state examination, physical examination, and then reading whatever you have written and considering possibilities. That's not what we do. We consider differential diagnosis right at the beginning, right? Then we think of differentiating between these possibilities. How would you differentiate? What can you do to differentiate between these three? Tell me things that you can do to differentiate. How to differentiate depression from anemia?
So we could ask for other anemic symptoms like palpitations,
Okay.
shortness of breath in exertion.
Yeah. Anything, something simpler that you can do? You can ask for those symptoms, raise. You can see if the patient is pale. What I want to tell you is it's not about asking questions. It's not about just asking questions. We can examine the patient here, right? Right at the beginning, before we complete the history. Now we are trying to differentiate between the possibilities. So you ask questions and you can see if the patient is pale, right? Hypothyroidism.
Signs and symptoms like lethargy.
Something that you can differentiate between the others. Now, lethargy will have in depression and anemia as well.
So like cold intolerance.
Cold intolerance is one thing.
Constipation.
Constipation, yes. Other than questions, what else can you do?
You can observe a puffy face, edematous face,
Yes.
loss of lateral 1/3 of the eyebrows.
I couldn't hear you properly. That's all right. Yeah. Any observations other than edematous feet? You can look for the
goiter.
Yes, for goiters. Right? So you can do simple things like that. Now, what I want to tell you is you can do your observations, ask your questions, and even look at investigations if patient have those investigation. Now, for example, if you think of anemia, you can ask the patient if they have got any full blood count recently done with them. And you can have a look at that and see if the HB level is low, right? And then we try to differentiate. Say I have summarized that the things that I would do to differentiate between these things. Right? Now, feeling hopeless about the future would be something rather specific for depression, some non-biological symptom of depression. And for hypothyroidism, enlarged thyroid would be the most obvious clinical sign that point towards hypothyroidism or some thyroid abnormality, right? And palo would point towards a diagnosis of anemia. Now, see, we can look at whether the HB level is low as well. And with the answers for these questions and the observations, there is no cold intolerance, no thyroid lumps, full HB is decent, no palo. Then we can organize the diagnostic possibilities in a hierarchy, and now depression comes on top after this exercise. Right? Anemia and hypothyroidism become less probable. Okay. Then we can consider a depressive episode as the most probable possibility for this clinical picture, right? And then to decide whether it is moderate or severe or mild, you have to ask those questions, differentiate between the severity of a depressive episode. And then now we have come to a decent diagnostic possibility here. Now the next step is, now in assessment, our first priority is to come to a diagnosis if possible. But that's not the only objective. After coming to diagnosis, or after narrowing down the diagnostic possibilities, we need other information related to management of the diagnosis and possible etiologies, right? Triggering factors for the current episode, such things. Now, let's say we consider depression here as the most probable diagnosis. Then we would like to know about etiology. Etiology could be biological, okay? And in that case, we would like to know whether there are other family members who have had psychiatric illnesses, depressive illnesses. If they have such family members, if they have such a family history, that means that their chances of diagnosing depression becomes much more probable, right? They are genetically vulnerable to develop depression, and then on our list of hierarchy, the depression comes further on top, right? We would like to know whether the depression was caused by, as a side effects of medication, certain antihypertensive drugs, steroids, and various other medications that we use for other illnesses could give rise to clinical depression, right? Or whether there are any psychosocial etiological factors, whether they have had some stressful life event, right? Some traumatic event that gave rise to a depressive episode. And let's say they have had previous depressive episodes and they are having recurrent depressive disorder. And this is another an episode of depression which was there in the past. In that case, we would like to know what triggered this current episode, right? Whether they had an infective illness, whether they had some life event, some trauma, right? Workplace problems or whatever, triggering the current episode. And then we would like to know some treatment related information, whether they have any other comorbid illnesses. Now, for instance, people with depression, if they have comorbid medical illnesses like diabetes or ischemic heart diseases, that precipitates their depressive illness, right? And if they have, and vice versa, right? And we would like to know what kind of family support the patient is having, because that information is relevant for us to manage the patient, right? To arrange medications, other psychological interventions, etc. And we would like to know the patient's insight about their illness, because if the patient doesn't think that they need medications, or if they don't have trust about, let's say, Western medication, right? Some people say they prefer Ayurvedic medications or traditional healing. That means that they don't have a lot of trust about our way of treating them, and we need to inquire about that in the management to build a good therapeutic relationship as and for such things. and side effects of previous medication. Let's say we diagnose depression, and then he was diagnosed patient with depression in the past, and he stopped taking medications because of some unbearable side effects for antidepressants. You would like to know that to think of some other medications this time. So after coming to probable diagnosis, we need this kind of information, additional information for these purposes, right? Now, I have summarized that in the middle column. Now you have your assessment method, which I showed you at the beginning. This one, right? You have this presenting complaint, history of presenting complaint. I guess most students used to follow this sequence from the beginning to end, and then write it down, and then think of diagnostic possibilities, etc. But the method that I am suggesting you to follow doesn't have this sequence. This doesn't have this sequence. So how does this apply to what I have told you? That is, now you follow this sequence, and while to follow this sequence, you need information from different parts of your formal assessment method. Now, for example, the initial complaint the patient gave after you asked your open-ended question. The question was, what brought you here? මොකක් වෙලාද මෙතෙන්ට ආවේද? ඒක ඇහුවට පස්සේ patient කියන දේ මේ තියෙන කෑල්ල, that is the presenting complaint, right? In our formal assessment method. And then we think of possibilities, and the things that we do to differentiate between these possibilities cover many other aspects of our assessment method. Now, there is history of presenting complaint. There are components of mental state examination. For example, look for the depressive mood, right? And physical examination. We look for thyroid lumps, right? We look for investigations as well. Look at past medical history, past psychiatric history. So all those things come at this point, right? And after coming to a decent diagnosis, for management purposes, to identify the etiology, triggering factors, these other aspects of the history, other aspects of the assessment method comes in place. Now, how do you make sense of this? What I suggest you do is, what I used to do is, I have this kind of now this is how you record this, record the information. Now when I assess the patient, I followed this sequence. And then this is what I did. But when I record, I followed the method on this side. I follow this method, this one. I follow this sequence for recording purposes. If someone looks at my record, what I have written down, they will think I started from presenting complaint and then ended with physical examination. Then at the end, after examination, I would write my differential diagnosis. Most probable diagnosis is a moderate depressive episode. Then I'll write down the outline of my management. That's how I would do. Looking at the record, you will think that I followed this sequence, but I did not, right? So you can do the same. You can follow this sequence and record it like this. Now, how I would do this in, let's say, in an exam setting, that's the most pressing concern for you at the moment, is I would have on an empty piece of paper, I would write down the topics, introduction, then presenting complaint, history of presenting complaint, and blank spaces to write down. I can't write in sentences in an exam setting. I would highly recommend you to write in this format, in short, like point form. Right? Most students I have seen writing in full sentences. You don't have that time in the exam. You will get stressed to write that much of an essay. You don't have that time. You are lucky if you get that time, but most of the times you will find it difficult to find that time, right? So I will have the topics and empty spaces: presenting complaint, history of presenting complaint, and family history, personal history, according to that order that is there in the book. And then I will follow this sequence. I will ask these questions, do these observations. Now, when patients tells me this bit, I'll write that down under the history of presenting complaint. Right? Presenting complaint and history of presenting complaint. Then I will do my things, my questions and observations to differentiate. I will write those down in the mental state examination. Mood is depressed, or that the patient doesn't have a goiter in my physical examination. After mental state examination, I will have physical examination, and under that heading, I will write that there's no thyroid lump. I didn't see any thyroid lump. No pallo, not pale, and things like that. So you have a clean, decent record that looks like you followed that ideal method in the book. Right? Is that clear for all of you up to that point? And when you present in the exam, or when you present this to somebody else, you can follow this sequence. You start with the presenting complaint, history of presenting complaint, family history, and you follow this sequence. And at the end, you give your differential diagnosis and the management plan. So it looks like that you did not deviate from what is there in the book, but actually you followed something more logical and practical than that, right? Do you have any questions up to this point? I would like to discuss this. If you have suggestions, if you think this is not practical, such things, you have to tell me. Then we can improve this further.
Excuse me, sir. Hello.
Yeah, I can hear. Yeah.
So suppose if you think that this patient must be having a bipolar affective disorder, and this time he is presenting with the depressive episode.
Yeah.
So how do we need to? How
Yeah.
are we going to elicit?
Yeah, that's what you do is, now here you thought of a moderate depressive episode, right? With this clinical picture. And now this moderate depressive episode, now you came to a possible diagnosis. Now this depressive episode could be a part of recurrent depressive disorder. This depressive episode could be a part of bipolar affective disorder. Right? And then you have to differentiate between these two. Now, after this point, you will have to do things to differentiate whether this is recurrent depressive disorder or bipolar affective disorder. How do you do that? I didn't mention that here, but let's say before coming to the etiology of depression, somewhere here you have to differentiate whether this is recurrent depressive disorder or bipolar affective disorder. How would you do that?
We can ask about his past psychiatric history.
Yeah, you can ask about past psychiatric illness, past psychiatric history. Especially, what do you look for specifically?
Were there any depressive episodes or manic episodes?
Yes, specifically look for whether there were any manic episodes in the past, or whether all the past episodes were depressive episodes. So, how would you elicit the possible manic episode in the past? What would you ask? You can't observe that. That is something in the past. So, only thing you can do is asking. You can ask for symptoms of mania. What would you ask?
So poor sleep, high expenditure of
Anything
money.
specific? Poor sleep could be a part of depression, could be part of mania.
Excessive expenditure of money.
Okay. when you are paid at the end of the month, you spend a little bit more than usual. So what you need specific things to differentiate between possibilities. Those questions are okay, but can you improve on those questions? Can you think of better questions? Because you have limited amount of time. That's the problem.
But there are any instances where he had felt happiness.
What kind of happiness? Because we all feel happy, you have to ask something very specific that patient understands. A happiness that is, what sort of happiness is that? If you ask something general, less specific, have you felt happy in the past? They will say yes. And you don't know whether they have been manic or not. Can you see what I'm trying to teach you now? You have to be very specific in your questioning because you have a limited amount of time. That's how you make this efficient. By saving time, by asking the very specific questions, making very specific observations.
Any inappropriate behavior according to the place and time?
What do you mean by inappropriate? Single කිව්වොත් මොකක්ද අහන්නේ patient?
මොකක් හරි සීරියස් වෙලා ඔය කියන්නේ අපිට මලගෙදරක වගේ ඒ වගේ වෙලාවක අර අනවශ්‍ය විදිහට
ඔව් මලගෙදරක් තිබිලා නැත්නම් මැනික් වෙලා. ඒක මම කියන්නේ අර අපි දැනගන්න ස්පෙસિෆික් ඒවා අහන්න ඕනේ. No, I'm not laughing at you, but you know, this is how you learn the art of questioning. You ask the wrong questions and then you realize that that's not the most appropriate. Can anyone else think of something specific? And okay, you think of that. All of you, when you do your assessments, when you see your patients tomorrow, think of better questions and ask a question and see the response of the patient and see if that answer served your purpose. You need to have a purpose. Your purpose is differentiating between a manic episode and depressive episode in this case, like you suggested. Now, try to do that with one question or two questions. You can't ask 10 questions. You don't have that time. Time is a limited factor here, right? All right. Any other questions?
So similar to the previous questions, is the patient present with something like auditory hallucination? Then we can think of, and he also complains of some depressive symptoms as well.
Yeah.
Then if we suspect that this may be due to either due to a depression with psychotic symptoms, or else we can also think about like schizophrenia like diseases.
Yeah.
So then at what point do we need to exclude, need to ask questions to differentiate those two?
Yeah, but yeah, that's another thing, a common thing. How would you differentiate? You can ask for other symptoms of schizophrenia, other very like specific symptoms of schizophrenia. What are the more specific? I mean, you don't have diagnostic symptoms of schizophrenia, but what are the symptoms that you know which leads to a diagnosis of schizophrenia?
Third person hallucination.
All right.
Then we have delusions, like delusions of control and prosecuted delusions.
Delusions of control or delusions of passivity are quite almost characteristic of schizophrenia. So you can ask such questions, right? So what I want you to learn here is you need to look for or study some characteristic features of particular illnesses that you know. What are the characteristic features of schizophrenia? What are the very specific symptoms of depression? What are the very specific symptoms of anemia? What are the specific symptoms of hypothyroid? You need to know. You have to have those little small questions or observations which points towards a particular diagnosis. You need to know, you need to have that knowledge to utilize this method efficiently. Right? You need to have some background knowledge. That's why we are teaching this to the final years. Now, for a first year medical student, it could be difficult without a background knowledge to apply this method. Let's take another couple of examples and finish this and try to apply this in the ward class. This is the first example. Okay. A man brings his 18-year-old son to the OPD, who is repeatedly checking if the doors are closed. He's anxious, gets startled by noises. Father noticed that he's self-isolating. He would answer your questions but doesn't speak spontaneous. What are the possibilities you think of? Imagine.
So OCD.
Okay. OCD is one.
Generalized anxiety disorder.
All right. Could this be psychosis? I would think about these possibilities. You can disagree with me and you can add to this list or remove certain things. Why do I think about psychotic disorder with paranoid ideas? There are no clear psychotic symptoms here. There are only certain observations. Let's say I consider psychosis because this repeated checking of the doors, this phrase is quite characteristic of an obsessive compulsive disorder, but we don't know. Right? We only have this observation. We don't know what's going on inside the patient's mind. Now, with one observation, we can't diagnose OCD. We can think of the possibility of OCD, but now if I am paranoid, if I am psychotic, if I had paranoid delusions that someone would come to kill me, won't I behave in the same manner? I would check that if the doors are securely closed at night, because I'm frightened, not because I am obsessional, because I'm frightened for my life. And I would be anxious and I'll get startled by noises because I'm feared for my life, right? I would isolate myself because I don't trust anyone. So this could fit into this could fit into a picture of someone behaving in response to a persecuted delusion. This is particularly important in essay questions we ask in the final year, the essay paper. We give this kind of a scenario and ask for differential diagnosis, and people write obsessive compulsive disorder, and that's it. The usual question format is, what are the possible differential diagnoses and how would you differentiate between your those things that you mentioned in part 1, right? There we expect you to write this kind of broader possibilities: obsessive compulsive disorder, depressive illness, psychotic disorder, and then you have to differentiate between them, right? How do you find out whether this door checking is obsessional or psychotic thing? You can ask something open, such as, tell me more about your checking doors at night. If you leave it as an open question, they might tell you that, Dr. මට හිතට එනවා දොරවල් ලොක් කරලා නැහැ කියලා, මට ඒක නවත්ත ගන්න බෑ, ඒ නිසා මම ගිහින් check කරනවා. The psychotic person will say, somebody is coming to kill me, therefore I check the doors, right? If you want to further make sure that it is obsessive compulsive disorder, you can ask direct questions about obsession. Do you get intrusive thoughts, irresistible, to check the doors at night? This is very specific for obsessions. We are asking whether they have obsessional thoughts. Intrusive, the patient cannot resist. They also know that they are senseless. The second question, do you think something or someone is out there to harm you? Is to look for a possible delusion, a persecutory delusion or persecutory idea. Let's take this one as well. This is the last one. Second example. I don't have 10 examples. I asked what brought them to the hospital, and then they say, my heart suddenly started racing. I was sweating and I felt so agitated. There was a discomfort in my chest. Tell me the possibilities.
Maybe having an arrhythmia, and it may have caused palpitations.
Yeah. What else?
Can be due to anxiety disorder.
What kind of anxiety disorders? Panic attacks? Could be arrhythmias. Could this be hypoglycemia? Hypoglycemia could present like this, isn't it? How would you look for, if you think of an arrhythmia, what can you do to differentiate that from panic attacks?
So can ask for syncope-like features.
Okay.
Dizziness, or else we can perform an ECG.
Something that you can do instantaneously at that moment.
Can check pulse.
You can check pulse. And what are you looking for?
Irregular.
Irregularity.
Pulse.
You can listen to the heart. That's why a psychiatrist need to carry a stethoscope. You can listen to the heart. You can check pulse. And if there is irregularity, then a cardiac arrhythmia comes on top. It's not panic attacks. Especially when you work in general settings, like in outpatient department, you need to have this. You need to consider these things. Right? Panic attacks, these are the things that you can see. For hypoglycemia, history of diabetes, medications. See, you can do finger pricking and then check random blood glucose. So that's the outline of today's class. If you have any questions, you can ask now. I don't have anything other than this for today. These are two additional points. Some patient with psychiatric problems, I might find it difficult to express the presenting complaint. Some of them will say, I don't have any problem. What are you going to do for them?
So collateral histories.
Okay, collateral history. If there is no one present with the patient.
So we can do mental state examination.
You can do mental state examination. You can do your observation. It's not only the questions, right? If the patient doesn't speak, you'll observe them, examine them, and see if you can obtain a collateral history. That's what you do. All right. I prefer gathering information from the patient always over a collateral history, because you get first-hand information from the patient. Collateral history is second-hand information from someone else's perspective. And some patients might continue talking. When you ask an open-ended question, they will continue talking until you stop them. When do you decide to stop them? You decide to stop them when you realize that no new information is coming up from the speech. He's talking about, no new symptoms are coming up. You might diagnose flight of ideas, overfamiliarity, disinhibition. But if nothing new is coming up, at that point, you might need to stop them. Otherwise, they will keep on talking and you might run out of time. Okay. Right. So this is the last slide. If you have any questions, I'll give you one minute and then we'll stop. Right. We'll stop here. If you have questions, you can ask me in the board. Try to apply this method. Now, since you have using something else for many years, you might find it difficult to apply this overnight. Right? You will have to struggle with this for a couple of weeks, but if you learn this, it will save you a lot of time and you will be able to make better diagnosis and better assessments with within a shorter period of time, and that will come in handy in exams and in any other clinical appointment as well. Now, this is not specific to psychiatry. Now, we took general examples from clinical medicine and other specialties, cardiology, etc. So when you do such appointments as well, this method will come in handy. Okay. We'll stop here today, and thanks for coming at this time of the night. I'll see you later.
Thank you, sir. Good night.
Thank you, sir.
Thank you, sir.
Thank you.